We have two eminent doctors who will be testifying in order. The first is Dr. Katharine Dalke. Dr. Dalke is an attending psychiatrist at the Pennsylvania Psychiatric Institute at the Penn State Milton Hershey Medical Center, which is a phenomenal resource. People around the world know Hershey, Pennsylvania for chocolate. I happen to be fortunate enough to live in a community where Hershey and Johns Hopkins are equidistant, and everyone, if they have any sort of a malady that requires more than what the local health service can provide, wants to go to Hershey because of really the phenomenal care that they provide. It's a phenomenal resource for our entire Commonwealth. Dr. Dalke is the director for the Office of Culturally Responsive Healthcare Education. She's assistant professor of psychiatry and behavioral health at the Penn State College of Medicine. And Dr. Dalke, I believe that you're with us.
Yes, I'm here.
Very well. Dr. Dalke, please feel free to go ahead.
If I may for a second.
Oh, yes.
Quentin, can you please turn off your microphone? Okay, we're good. Thank you. We can go.
Well, thank you very much for the introduction. And good morning, Majority Chair Rick, Minority Chair Frankel, Representative Demo, the members of the Subcommittee and House Health Committee. Excuse me. Thank you so much for this opportunity to speak with you all today about care models for transgender youth and adolescents. As Representative Chevrolet said, my name is Katharine Dalke, and I'm a psychiatrist who specializes in mental health care for sexual and gender minority adolescents and adults. I completed my medical degree in psychiatry training at the University of Pennsylvania, where I had experience in treating psychiatric illness in inpatient and outpatient settings. I also have additional training in transgender mental health in particular. As an assistant professor of psychiatry and behavioral health at the Penn State College of Medicine, I treat patients in the inpatient and outpatient settings at Pennsylvania Psychiatric Institute in Harrisburg, and also at the Gender Health Clinic at Penn State Children's Hospital. In a typical week, I provide mental health care services to up to 15 to 20 transgender and gender diverse adolescent and adult patients. I've also been involved in sexual and gender minority health education and research for 15 years, and I currently serve on healthcare research committees at the state, national, and international levels. Before I move into my testimony, I'd like to offer a couple of definitions just to ensure that we're all speaking the same language. And I appreciate Representative Delacier's acknowledgement that this language is complicated and shifting. So for the purposes of my testimony, transgender refers to the experience of having a gender identity, which is how we feel about our gender inside, that does not align with the sex that we are assigned at birth. Gender diverse includes people who are transgender, people who have a non-binary gender identity, and people whose gender expression, which is how we present our gender to the outside world, does not conform to societal expectations. I'd also like to acknowledge that because I am not transgender, I can't personally speak to what it's like to be transgender. My testimony today, rather, is informed by a synthesis of the best available medical evidence, my clinical practice in community and academic mental health settings, and input from colleagues who are transgender identified mental health providers and physicians. I would also submit to the subcommittee that caring for trans youth and their families has been one of the greatest privileges of my life. On a daily basis, my patients and their families teach me about what it means to be resilient and courageous. As I move through my testimony, there are 5 key points I'd like to convey. The first is that trans identities and gender diversity are not mental illnesses, but normal aspects of human diversity. Second, trans and gender diverse youth are vulnerable to higher rates of mental health problems, suicidal thoughts, and suicide attempts. And importantly, these mental health problems are due to the combined stress of gender incongruence and social stigma. Gender-affirming mental health care, which is what my testimony focuses on today, aims to reduce these mental health problems by promoting resilience, helping their support system to accept them, then facilitating connections to medical care when appropriate. Withholding gender-affirming care for the war from transgender and gender diverse youth has been associated with worse well-being and can potentially increase the risks for distress and suicidality. To highlight these points, I'd like to start with a story that is an amalgam of patients that I've treated in Hershey, Harrisburg, and Philadelphia. Mary is a 15-year-old child who was referred to me from an inpatient psychiatric hospital after a serious suicide attempt. While Jay was in the hospital, he told his mother for the first time that although he was assigned female at birth, he had felt like a boy for a long time. When I met with Jay, he told me that until puberty, he felt pretty good. His mother was fine with him wearing boy clothing and doing boy activities, and both of them really thought of him as a tomboy. Jay was especially delighted that strangers would occasionally call him he or him. He did well in school, had lots of friends, and was involved in extracurricular activities. He was close with his family and cared for his siblings while his mom worked her second job. This was one of his favorite responsibilities. When puberty started, though, Jay became depressed and anxious, and for a long time, he wasn't sure why. He did notice that it was less and less likely that people took him for a boy, and he started to feel anxious every time he was referred to by his female name or female pronouns. He started to be teased at school for being different than other girls, and so he stopped going. Eventually, he realized that an increasingly feminine body was physically uncomfortable for him, and he even began to self-harm by cutting his wrists with a razor blade when he got his period. He told me that the pain distracted him from the distress of having a period as a boy. He eventually became suicidal because he was afraid that he would never be able to be seen as a man, and he didn't want to live life as a woman. And he only told someone because he realized that he couldn't survive if he didn't. Much to his relief, his mother was supportive, and she was relieved that he was finally telling her what was going on. He began calling him son, Jay, to leave him, and started to feel better. Together, they approached school, and the principal and teachers began to respect his name and pronouns as well. Over the course of several months, Jay talked with me and a therapist and learned more about what his options were to feel at home in his body. He began wearing a tight top to flatten his chest and started a birth control injection, Depo-Provera, to stop his periods. 6 months after I had met Jay, birds were improved and he was back into his extracurricular activities. He told me he hadn't had any suicidal thoughts or any self-harm in several months. He was hoping to start testosterone at some point, and his mom said she was going to pay for it, but he really wanted to get a job so he could cover his own co-pays. His mother told me carefully that she finally felt like she had her child back. Although Jay's story is not the story of all youth, as you'll hear, there are many things about it that are common. While roughly 1% to 2% of American youth identify as transgender, up to 20% of American youth describe diverse gender expressions. Trans people, furthermore, have been represented throughout history and literature for thousands of years and in cultures across the world. These experiences of trans identity and gender diversity are recognized as common and normal aspects of human diversity by major medical organizations like the American Academy of Pediatrics. However, we also know that in the U.S., there is strong evidence that trans and gender diverse youth are vulnerable to higher rates of mental health problems. Studies have consistently found over the past 20 years that trans and gender diverse youth report higher rates of depression, anxiety, psychological distress, eating disorders, and substance use problems relative to all youth. We also see significant suicide disparities, and as a psychiatrist, this is extremely concerning for me. In one study, 94% of trans youth said that they wanted to die at the time of the study. In another survey, 5% of trans youth reported having attempted suicide in the past year, which was compared to 8% among all American youth. Unsurprisingly, as a result, and this can see both in the literature and in my clinical practice, trans and gender diverse youth often receive intensive and expensive levels of mental health care, like multiple inpatient hospitalizations, partial hospitalizations, intensive outpatient programs, residential treatments, and often extensive psychiatric medication trials. Sadly, these treatments are really only partly effective at best for the majority of youth because they really fail to address the core issues. However, there was strong evidence when trans youth have family support and affirming mental care, they're just as happy and healthy and successful as any other young person, and in some studies, even more so. In other words, these mental health problems are not intrinsic to being transgender, but rather due to a combination of gender incongruence and social stigma. For gender incongruent stress is sometimes also referred to as gender dysphoria or body dysphoria. It can take a couple of forms. Some youth tell me that, like Jay, they're actively distressed by their physical sex traits, the shape of their chest, facial hair, the pitch of their voice, their genitals. Other youth aren't maybe not so bothered by their bodies, but feel really bad when they're misgendered by other people, when someone else refers to them by the wrong name or the wrong pronoun. What I see over and over again is that this distress can manifest pretty diversely. Some youth have anger outbursts, other youth are prone to depression or anxiety, and many youth have suicidal thoughts related to this distress. It's also common for youth to take substances or self-harm to help relieve this distress. However, some people are not aware of feeling distressed until something changes. One transgender youth published the following accounts of his experience wearing a binder to flatten his chest. Before I had my binder, I was anxious and uncomfortable wherever I went. I felt as if my skin was visibly crawling over my bones and sinew, and everyone who looked at me could see it. After I started binding, I felt normal, like any other average person on the street. Being glanced at was no longer a humiliating experience. I had no idea that I carried that much bacteria until I had a way of relieving it. Socially, like all children, trans youth are vulnerable to a number of stressors, lack the ability to change their circumstances. We also see clinically in the literature that trans youth are vulnerable to unique stressors because of their gender. In particular, trans youth, especially youth of color, are more likely to experience social isolation, verbal harassment, and physical and sexual abuse, both at home and in school. Because of this rejection and violence, trans youth are also more likely to be kicked out of their homes and to leave school. This, in turn, increases trans youth's risk of homelessness, lower educational attainment, placement in the foster care system, incarceration, and poverty. All of these stressors combined heighten mental health symptoms and suicidality, just as they would for any person, regardless of their gender identity. And it turns out that family and social acceptance ultimately has the single greatest impact on keeping kids in school and in their homes, which in turn can significantly reduce suicidal thoughts and behavior. So trans and gender diverse youth are not inherently mentally ill, but you require affirming mental health care to reduce the impact of social stigma and gender incongruence on their mental health. The literature has shown that gender-affirming mental health care, as part of gender-affirming care more broadly, can significantly improve mental health and well-being. In my practice, and according to the best practice recommendations, gender-affirming mental health care starts with a comprehensive mental health assessment for all youth, which is designed to evaluate the youth's strengths and coping skills, their emotional distress and symptoms, including evaluating whether there are any psychiatric illnesses or problems that might be ongoing, consistently assessing for and trying to reduce risk factors for problems with safety, and also assessing their support system. Importantly, my job is never to decide whether or not a person is transgender, or to assume that I know what they want or will need now or in the future. My job instead is to listen to and support young people in exploring their gender identity and expression, and to think with them about what this might mean for their eventual social, legal, and medical goals. The strategies we use to help support youth in this process include frequently asking Taylor and a family name and pronouns, connecting you to good support. And we're very fortunate in Pennsylvania to have a number of local peer support groups for our youth. Encouraging exploration with gender expression like hairstyles, activities, and hair. Working consistently and assiduously to manage suicidal thoughts, social stress, and disclosure of what's going on to other people in their lives. And a big part of gender-affirming mental health care that's often overlooked is providing support and education for families. In my experience, most parents bring their child to mental health care because they want to be able to support their children, but they might need some help figuring out how. Part of my job is to help them understand that their support of their child is perhaps the single most important thing they can do to protect their child from harm. And what I've seen over and over again is that the majority of parents really come to be able to adapt to and even celebrate their child's gender. Because many families, importantly, may have trouble accessing mental health care for themselves. And I'm sure you all know that this is a challenge, especially for families in more remote or rural parts of the state rather. And also because they might be shy about discussing this in their communities. These conversations with their child's provider can really be crucial to improving the health of the family as a whole. Gender-affirming mental health care does also include educating youth about the menu of legal and physical options. You'll hear more from Dr. Dalke in her testimony about these options. I won't go into them in detail right now, but I will say that in my clinical practice and in the literature, we see over and over again that not all youth want all available intervention, which is why I never assume that all youth will want a really specific intervention. It's also important to understand that interventions that we consider partly reversible or irreversible are rarely considered until the youth is late in adolescence. This education is really important for us to provide because all guidelines require that a minor have a letter from a mental health provider before they can start a partly reversible or an irreversible option. For some youth, frankly, this can be a really hard area. If they're not able to find an affirming mental health provider or they don't have people who will take them to an affirming mental health provider. But when affirming mental health care is available, accessible, and expedient and efficient, a lot of youth seem to find this beneficial. It gives us an opportunity to have an in-depth discussion about the potential risks and benefits of a given intervention, which is a decision almost all of my patients take extremely seriously. It also gives them an opportunity to have an affirming and supportive relationship with a medical provider, which is often the first experience like that most of us have. And we'll also say that expanded access to telehealth during the course of the pandemic has been very important, in particular for family and gender diverse youth with less supportive families or in rural parts of the state. The literature and my clinical experience has shown that outcomes in general from this approach are very good. We've seen at the population level that affirming care reduces psychological distress and suicidality and improves well-being. Many youth end up requiring much less mental health care than they would have otherwise, and a significant proportion of my patients end up needing no mental health care once they are adequately affirmed. We also see from clinical studies extremely high rates of satisfaction with care. And it's because of this data that gender-affirming care, including mental health care, has been deemed as medically necessary by all of the major medical organizations involved in pediatric medicine, adolescent medicine, psychiatry, and psychology. Finally, there's evidence that shows that the opposite is true for approaches that withhold gender-affirming care from trans and gender diverse youth. There's literature to suggest that it is unlikely that a young person with a gender incongruence distress diagnosis, like gender dysphoria, that presents or persists at or after puberty will not identify as transgender as an adult. So what this means is that by the time most youth are coming to us in adolescence with distress, most of them will be identifying as trans as an adult. And when watchful reading in particular really fails to support a youth's gender identity, even socially, it can expose them to significantly more harm. And many of us who are who are doing this work on a daily basis really understand this approach that fails to support a youth's gender identity or waits for them to grow out of it to have higher risk than some of the strategies we use to affirm youth. Finally, there are psychotherapies that aim to change a youth's gender identity. These are sometimes called gender identity change efforts or conversion therapy. There's been good recent evidence that suggests that overall these approaches really lack evidence of efficacy, and that youth who go through them have evidence of higher rates of distress and suicide attempts, including well into adulthood. As a result of this, these therapies have been decried by JAMSA and major medical organizations across the U.S. So in conclusion, the best available medical evidence shows that gender-affirming mental health and medical care really significantly improves the health and well-being of trans and gender diverse youth, just as it has for the scores of transgender and gender diverse youth in Pennsylvania I've had the privilege of treating. Thank you very much for your attention. I'm happy to take questions, and I will introduce myself after a bit to go to clinic. Thank you.
Thank you, Doctor, for your testimony. Two things I neglected to reference at the very beginning of the meeting. Number one, we did receive a request from the Pennsylvania Youth Congress to film or photo during the hearing, and we appreciate the request, and that request was granted. We welcome you to be here. And secondly, Dr. Dalke, I appreciate all of the footnotes that you provided to evidence in your written remarks. The subcommittee is familiar with a number of these resources, but not all, so we'll be following up with those. With that, what committee members would like to ask questions? Chairwoman Delicio, please.
Thank you. Appreciate that. May I refer to you as Dr. Dalke? I know that very often now when you go into a healthcare provider's office, any number of screenings are sort of standard, including standards for abuse. As I grow older, about, do I feel unsafe in my home, things like that. Are there routine screenings that are part of pediatric medicine to kind of I'll use the term suss out whether this may or may not be an issue? Because I would imagine, I have no children of my own, but I have 8 nieces and nephews that are near and dear. And sometimes, you really have to give children a very comfortable opportunity in order for them to share. So is there any type of screening that has become routine, perhaps during a wellness visit, that would give a provider, a healthcare provider, the opportunity to perhaps pursue something a little bit more so they could be as supportive as possible of their patient?
Yes, thank you very much for that question. I appreciate that. And you're reminding me of a statistic I referenced in my testimony, which is that in one study, trans youth reported they had understood their gender identity 10 years before they ever told someone else. And that's one of the reasons why, actually, as many of you will not share this information with other people unless they're asked or unless they feel safe to do so. In pediatric medicine, in particular with adolescent patients, it is recommended as part of routine screening to ask all patients about how they feel about their gender, just as we ask them how they feel about dating and their interest in other people. Best practices also in general recommend for all patients, regardless of their age, that we ask all patients what name they'd like to be called and what pronouns they use. So this is another way that we can indirectly invite people to share this information with us. So yes, it is part of routine screening for adolescent patients, and best practices recommend really for all patients this be something we consider.
Well, one other quick question, and then Paul, maybe you can just circle back if we have a chance for a second round. Do you happen to know, Dr. Dalke, how many gender health clinics are in Pennsylvania? I'm aware of the Hershey location, CHOP, obviously. I think there's one out in the Pittsburgh area.
Yes. So to my knowledge, there are 3 integrated gender health clinics for trans youth, which include young patients before puberty. And those are at the University of Pittsburgh, Children's Hospital of Philadelphia, and Hershey. There are also individual providers and clinics across the state that will also provide affirming care to trans adolescents, although our youngest patients do often have difficulty accessing care. But there are really excellent programs up in the State College area and in Northwestern PA as well. I'm sorry, Northeastern PA, excuse me.
Thank you. Thank you, Chairman.
Thank you, Chair Delissio. Chairman Frankel.
Thank you, Chairman Schemmel, and thank you, Co-Chair or Democratic Chair Delissio. Appreciate the opportunity to have this testimony today, and I want to thank Dr. Dalke for taking the time to join us. And in particular, I'd like to ask you to address some of the misinformation that went unchallenged when the last hearing went forward without the attendance of any experts in the field. So a couple of things. A previous testifier argued that puberty blockers are likely to cause negative psychological effects. Can you speak to that? And I'd also, one of the other testifiers talked about, argued that pre-homosexual children are being mischaracterized as transgender. And can you discuss the difference between gender and sexuality?
Yes, thank you very much for those questions. So to address the first question regarding psychological outcomes with puberty blockers, we know, so puberty blockers, it's important to note, have been used for a long time for young people with precocious puberty. So these are young children, sometimes as young as 4, 5, or 6 years old, whose bodies start to naturally go through puberty on their own. Medications, we've used puberty blockers in those young people to help postpone puberty until they go through puberty at a more developmentally usual age. So we do have data from those sets of patients to help inform some of our understanding. And there have been some early concerns about puberty blockers affecting cognitive development. Those concerns are really not well understood. And the other concern that we have about puberty blockers is for bone health. So if we prevent the body from being exposed to hormones, like sex hormones, it can affect the development of the bones. This is why people, after they go through menopause, have higher risks for osteoporosis. The really crucial thing, though, to keep in mind with trans youth is that when they're taking puberty blockers, it's typically for a very, very short period of time, usually just a couple of years. And there's good evidence that shows, including some recent evidence that was published even just this year, that when young people have access to puberty blockers, their psychological outcomes, including their risk for suicidal thought or behavior, is lower than it is for trans youth and adults who are not able to access puberty blockers. And this is in the study I'm referencing from earlier this year. We saw those effects even when people had social support. So people who had social support plus puberty blockers did better than people who had social support without puberty blockers. I think the other thing that we have to keep in mind is that we have to weigh the risks of taking a puberty blocker against the risk of not taking a puberty blocker. So when a young person doesn't take a puberty blocker, we certainly see higher risk, as I said, of psychological problems, but we're also exposing them to the hormones that their bodies produce, which can lead them to develop irreversibly sex traits that they may not want later in life, which could put them at risk for needing surgery later in life. So one of the things I say all the time is that in medicine, there's nothing that has no risk. It really ultimately becomes about weighing the relative risks and benefits for an individual person. And on balance, we believe, based on the evidence and on clinical outcomes, that the benefits of puberty blockers outweigh those risks. Regarding the question about pre-homosexual children, I think what you're getting at is some of the literature around what's described as desistance. So there were a series of studies that were published that suggested that if you take youth who are presenting with gender questions, 80% of them will not identify as trans later in life. It turns out that those studies had some really serious methodological issues. So one of those issues was that they were including young people who were gender diverse, meaning they had a gender expression that was diverse in some way, like a tomboy, for example, but not necessarily youth who were transgender on the basis of a gender incongruence diagnosis, like gender dysphoria or gender identity disorder, which is an older diagnosis used in the psychiatric literature. When you look at the folks who actually had those diagnoses, it is much, much, much less likely that those young people will persist. So really, what we see, and without having in the previous testimony personally, we know that not all youth will want all interventions, and we know that not all youth will identify as trans when they come to us. So the approach is really not a one-size-fits-all one. It's one that's really youth-centered, family-centered, and led. And we really work with people over time to help them achieve their individual goals as they come to understand their identity.
Thank you.
Thank you, Chairman Frankel. Representative Zimmerman.
Thank you, Chairman Schimmel and Dr. Dalke. Appreciate your testimony. Just a couple questions. One, when did the Gender Clinic in Hershey open? How many patients are being seen each year, and is that number increasing?
Excuse me. So Hershey has been providing care to trans and gender diverse youth and adolescents for 15 plus years. Over the past year and a half to 2 years was when we really formalized the structure of care for trans and gender diverse youth, so that was really integrated. So our clinical program includes a psychiatrist, who is me, a licensed clinical social worker who's our gender therapist and coordinator, an adolescent medicine physician, and 2 pediatric endocrinologists. So we've been really working together over the last couple of years to have an integrated program. I don't, off the top of my head, know the exact number of families that we're serving, but it is, at this point, is over 100 patients, probably close to 125 would be my guess. And it's hard to say really whether that number is increasing because we're still relatively early in the process of having this integrated program. But we do expect those numbers to increase over time.
Also, how many biological girls versus biological boys, and what is the youngest age that you might treat?
So I don't have the exact breakdown of how many children you take care of who are assigned female at birth versus assigned male at birth. And those numbers vary from clinic to clinic and across countries. The youngest age of patient that we will see is really as early as families are ready to bring them for care. We do not provide any medical care for any young person. The only time we think about medical care is when someone is starting to go through puberty, which is on average sometime between 10 and 13 or 14 years old. So while we may take care of some people who are in elementary school, those young people are not receiving any medical care. They're receiving psychological and social support.
Okay, appreciate that. And one last final question here is, so do most children come before puberty or after puberty to your clinic?
So in our clinic, the majority of our patients are presenting during or after puberty. From informal conversations with other programs, as programs are open for longer, they do start to see patients younger. But at this point, most of our patients are in or after puberty.
Okay, thank you. Thank you, Mr. Chairman.
Thank you, Representative Cox.
Thank you, Mr. Chairman. Thank you, Dr. Dalke. A few questions kind of came to mind as I'm listening to your testimony. When you first see a child, that first meeting, do you evaluate in that meeting whether you believe the child is transgender diverse or gender dysphoric? Do you draw that conclusion in the first meeting, or what's your process there?
So I I never decide whether a young person is transgender or gender diverse. That's ultimately for the young person to decide. One of the things I do evaluate in the first hearing is whether someone meets diagnostic criteria for a gender incongruence diagnosis, which in my case is gender dysphoria. Um, Sometimes in the first meeting, I am able to identify that with certainty. Sometimes it takes more time than that. What I will say is that for young people, we don't make that diagnosis without information from multiple sources, including the young person as well as their family members, and without evaluating for whether there might be something else going on that could better explain why a young person is feeling, for example, depressed or anxious.
Okay. And so I want to make sure I understand the distinction. Sounds like you're drawing a little bit of a distinction between diagnosis and recommendation. Am I being accurate there?
So, what I'm drawing a distinction between is labeling someone's distress and labeling their identity. I think the problem with labeling identity is really two. One is that's just not for me to decide. That's for the young person to decide. And number two, I really, as I said previously, I try not to make any assumptions about who a young person is or what that young person wants. So if someone comes to me and they have, 6 months of distress that's related to their gender identity, they've got a strong and persistent preference for activities or clothing or hairstyles that are another gender. This is happening at school and at work, and it doesn't seem like this is related to another mental health problem. Then we can give a person a diagnosis of gender dysphoria. But even that is not something we see all the time in the first visit. It really depends on the person's individual circumstances.
Okay. And do you, as a practitioner, practice affirmation during those early meetings?
I do actually. So in those early meetings, the way that I practice affirmation is really primarily through asking the young person questions and respectfully and validating their answers. So that might be something as simple as a person tells me that they go by they and them pronouns, and I use they and them pronouns when I talk to the young person. It might be that a young person tells me they really love Spider-Man, and so we have a 10-minute conversation about Spider-Man. For a lot of young people, they may not have those experiences elsewhere in their lives. For many young people, we do also recommend affirmation socially from the beginning. So we may encourage families to use the child's name and pronouns at home, or to allow them to encourage them to play with toys at home, for example. And part of the reason that we do that is it gives us really important data. When a young person is feeling significantly better with steps like that, then we know that we're on the right track. If they're not really significantly better with steps like that, then it means that we need to be thinking really carefully and clearly about what's going on.
Okay. So is there a point in there where you feel like you have enough information? Do you ever recommend surgery for these individuals? And if so, how far down the line is it before that recommendation is made?
Right. So what I would say is the only two medical steps that I ever recommend to people would be medication to stop periods or medications to delay puberty. And the only reason I recommend those is because, number one, a lot of young people and their families don't know those are options. And number two, especially with puberty is a time-sensitive thing. And I don't ever recommend by saying, like, this is something you really need to do or something terrible is going to happen. It's more along the lines of, hey, this is an option that's available to you. How would you feel about me scheduling you an appointment with a medical provider who can talk to you more about the risks and benefits? I have never recommended estrogen or testosterone or surgery to a person. If someone comes to me and says they really want to do those things, then we have a conversation about the risks and benefits for that individual person and really understand how that lines up with what their personal goals are. clinical guidelines in general recommend that hormones, estrogen and testosterone, not be prescribed before 16. The guidelines also acknowledge there are some circumstances in which that might be appropriate, but in my clinical practice, it's generally not usually common. And similarly, guidelines recommend that surgery not be performed before 18. Again, there's really just one exception where we think about that, and that's for people who have breasts who identify as male and who need a more masculine appearance to their chest. And sometimes we will consider that surgery in a 16 or 17-year-old. But again, that is very specific to the person and is not a routine practice, I would say.
Okay, I want to step back to a prior question. I kind of, as you were finishing up your remarks on the first, I had another question jotted down I wanted to ask, which I just did. But so you mentioned the Spider-Man conversation you have with an individual. We have another member of the subcommittee who wasn't able to be with us today due to a issue with the family. I think there was someone who passed in the family actually, and she described a scenario where one of her children wanted to be talked to and treated like a puppy. And so that lasted a while, and, they somewhat treated the child like a puppy, to the greatest extent possible. Forget how the story ended. It had something to do with a tail, I think. But beyond that, it's going to beg the question with me when you're speaking of Superman. The child likes Superman. Let's say the child believes they are Superman or Spider-Man, I think was the reference made. Do you affirm, or would you affirm a child saying, I'm Spider-Man? Would you affirm a child who came in and said, I want to be treated like a puppy? How would you handle those types of scenarios where a child is expressing certain things, whether it's the age of 4, 5, and 6, or whether it's a little older? How would you treat that?
So, I think the first thing to say is that it is really common for children to go through a developmental period that we call magical thinking, as far as, having the magical thought that they could be a puppy. And the difference often between gender identity and expression is that when young people come to us and they're talking to us about their gender identity or their gender expression, it doesn't have that same fantastical or magical quality to it. In fact, most young people feel nervous or anxious about realizing this about themselves because they realize that it's not common in their immediate surroundings for people to feel this way. So I think that's point number one, and why this is really different. I think the other piece of it is that affirming a child's gender identity does not exclude exploring what that means for the young person. So I can still say to a young person, refer to a young person as he and him, and have a conversation with that young person about what that means, whether they want to be called he and him at school, or whether it's just at home, whether it means they really just want to play with toys, or they also want to change their hairstyle. As people become older, magical thinking is much less prominent as we get into adolescence. So it's very unlikely that we see things like that happening, but the conversations are still similar. As I mentioned, not all people want all interventions. And so to me, you can affirm someone's identity without making assumptions about what they want and support them in making that decision themselves. And we do see this distribution of interest in medical care and surgical care, even well into adulthood. There are plenty of adults who are very interested in surgery and plenty of adults who are not interested in surgery.
And so prior to that surgery, you mentioned medications, or you looked at two medications or two approaches specifically is what I recall a moment ago. When you're walking through them with the good and the bad, the risks and so forth of those medications, is there an exhaustive discussion with those individuals about preserving function and fertility and explaining to them that there is a point of no return where they will lose functionality and where they will lose their fertility. Those are full disclosure type conversations, I would imagine.
Yeah. So, and frankly, they're conversations you start having with people when they're very young. When we talk about puberty blockers, we talk with people about how this might affect their fertility. When we talk about hormones and testosterone, like testosterone and estrogen, we talk about how that might affect their fertility. And certainly when we talk about surgery that would remove tissue that's necessary for fertility, we talk about fertility. And so, in my experience, most people have really thought about this in a lot of detail. And have really thoughtful answers to those questions. One of the things I think that's actually interesting is that there's a lot of apprehension about preserving fertility, but that's not a service that's actually covered by most insurers for people in Pennsylvania. So if a person, for example, wants to be able to freeze sperm, or a person wants to be able to freeze eggs, that can be very costly out of pocket for young people.
Okay, thank you very much for your answers.
Thank you, Representative. I understand that Representative Mary Jo Daley has a question. I think she's with us virtually.
Hey, I'm with you virtually, and I'm going to turn the camera on the unmute myself. So thank you, Chair Schemmel, for the opportunity to participate in this way in this hearing. I really appreciate it. Dr. Dalke, it's really, I was fortunate to be able to read through your testimony earlier today, but it's really good to hear it directly from you. I want to go back to what Chairman Schemmel talked about with why we're having these hearings, and that the question came up in the state when the governor made a statement that full health care for transgender youth would be covered by the state's Medicaid. And I realized as I was thinking through this and listening to some of the other conversation, the provider is not necessarily the best person to talk to about what kind of insurance a person might have. But I wanted to go back to some of the comments that you made about social stressors that youth are exposed to, and especially kids who, kids of color, Black kids, they are potentially getting more stigma attached to them, more isolation, and more possibility that these stressors that you discussed would end up with really negative kinds of outcomes for them as they get older, because they just don't have anyone to talk to. And so I guess what I could ask you to talk about is, when you have a population that doesn't or can't get treatment, and we know that there's supposed to be parity in mental health treatment, but we don't think there really is, how this can actually help kids who might be have Medicaid as their health care, or CHIP, those programs. It seems like it's really important to give them health care when they need it, because it's healthier, quite honestly, as they grow older. If you could talk about that a little.
Sure. So I appreciate you recognizing that I'm my skill set is not in policy. But so what I can say from the clinical perspective is that, so first of all, part of the agency see trans youth of color in particular experiencing significantly more mental health problems and symptoms is actually exactly related to what you're talking about, which is what we call intersecting stressors. So people experience not just stress and stigma related to being transgender, but they also experience stress and stigma related to being Black, for example, experiencing racism or racial discrimination. People who experience stress or stigma related to having a physical disability or a mental disability. And so we can see that those stresses can intersect to change someone's level of stress and change the burden of mental health problems that they experience. what I can say, and I didn't include these citations in my testimony, so I'd be happy to share them with the subcommittee. There have been studies that have compared mental health symptoms and behaviors in states that have affirming protective legislation and states that lack affirming or protective legislation. So there was a big body of work looking before the Supreme Court ruling on marriage equality. There were comparing mental health and suicide in states that had marriage legal and states that did not. And we saw that youth in states with marriage equality had lower rates of psychological distress and suicide. But it wasn't even just LGBTQ, it was actually all youth. And there have been similar studies that look at affirming protective legislation to protect kids from bullying, including states that name bullying on the basis of gender identity or sexual orientation explicitly. So I think from a policy perspective, this is one of those places where we say that not covering a particular trait of care for a specific population as a matter of policy becomes a social stressor, which we do see can influence people's mental health significantly down the line. And then the last thing that I would say is that, the youth in Pennsylvania, although, as I mentioned previously, there are programs across the state, many of our youth have a hard time with these programs, either physically or logistically, or figuring out them. And there are many additional barriers for our Medicaid youth as well, as far as being able to find a particular mental health provider in communities that accept Medicaid and have this as part of their skill set.
Thank you very much. And it would be really helpful, I think, for us to see the study of the states that have affirming care and those that do have affirming care. I think that would be useful. And then I think for our chairman, we should probably be at some point looking at those individuals who actually can, the health economics kind of side of this would be also interesting for a future hearing. So just something to think about.
Thank you, Representative Daley. Dr. Dalke, I have a few questions. So in my own mind, I sort of stratify, and I know this is an oversimplification of the different stages. So affirming is an initial stage as children explore, then puberty blocking drugs, and then cross-sex hormones. And for some, and I think you said, perhaps a minority surgery, but at each of those first three stages, affirmation, then puberty blocking drugs, then cross-sex hormones, in your own clinical experience, how many children, could you say this is a path of exploration, presumably some children desist, some children persist. So just approximately how many children desist after each one? How many would desist after just the social affirmation, would desist to their natal sex, and then once again, same thing, following puberty blocking drugs or cross-sex hormones?
Sure. So thank you for that question. And just to clarify one point, when I talk about affirming care, I really mean that as including the whole process that you described. It's not just the beginning. And I also wanted to be clear too that for youth in particular, it is standard care and expected as part of the guidelines that they have gender-affirming mental health care as part of every step along their physical path as well. So people often don't need to see me anymore necessarily as a psychiatrist because they don't make psychiatric medication, but we do expect and want them to have access to a therapist as they're continuing through this process. And many youth do come back to me, for example, when they're thinking about starting hormones or when they're thinking about having surgery in adolescence or in early adulthood. As far as the question of desistance, what I can say is that among the scores of patients that I personally treated, I've had one person later decide that they would not identify with their assigned sex. And so I say that very intentionally because this person ultimately decided that they identified as non-binary, but they did not necessarily identify as male, which was what their earlier gender identification had been. And what I learned from that, and what I've learned from talking with other providers and folks in the community and in some of the literature, is that that's when people are so-called desisting, it's actually not super common for people to desist back to their assigned gender. It's more common for people to say, I'm understanding my gender identity differently, and that has different implications for what my medical care looks like. We also know that the rates of regret for hormones and surgery are very, very low. But to answer the other part of your question, I because I've only had one person quote unquote desist, I rarely or never see people who will change their minds after a particular intervention. What I will see is folks who say, for example, someone who's assigned female at birth, who identifies as male, who will start this process, and maybe they'll wear a chest binder to flatten their chest, and they'll take medication to stop their periods, and they'll say, I feel great. I don't need anything else. I am a man, and this is what it feels good to. This is how it feels good to be a man, that I don't need anything else. So that's not someone changing their minds. That's someone just realizing where they are in this spectrum of gender and gender identity they fall. Does that help? Does that make sense?
Yeah, that does. So the first part, especially for prepubertal children, affirmation, that includes acceptance within the family, presentation as transgender, social settings in school, often changing name and clothing and so forth, and being part of a support group for those that are able to access that. I mean, wouldn't you agree that that would make it difficult for a child? They would be experiencing a lot of external pressure to persist. It would be difficult for them to, sort of go back after being fully accepted and integrated in that way. Would you say that that's true or not in your experience?
So I think that's a common fear that people have. What I think happens though is that when people, if someone were to find themselves in that situation, which again happens very infrequently, they don't feel better in the circumstances that they're in. So they don't necessarily feel better being called by a different name or different pronouns or being allowed to use different toys. And so, that becomes pretty clear, and people will change to a different course. I really believe that our children and our young people are extremely resilient and very capable of telling us what they want and need. And so I think it's very unlikely that someone would, their parents would let them play with Spider-Man toys, again, to use the same example, at 6, and then they would feel like they had to take testosterone at 16. That feels very, very unlikely to me. And I personally have never seen that happen.
Okay. See, in your testimony, you define gender identity as how someone feels inside. Given that you're diagnosing children, and some children who are very young, do you believe that it's likely that they have a full understanding of the significance of gender and sex? Or is it more likely that their feelings sort of evolve as their understandings of those two things evolve?
Yeah, so I'll share. So I had 2 children myself, and my almost 5-year-old is a girl, and she was absolutely she's thinking in this very kind of all or nothing and black and white way about what it means to be a girl. And so she decided that if you had long hair, you were a girl, and that girls couldn't have short hair. So I cut my hair very short, partly because we had a second child, but also partly to kind of push her on that a little bit. And it took her a while, honestly, to try to open up and recognize that girls could have all different kinds of hair lengths. And so this is something that we certainly see with folks who are very young. The way their cognitive processes work influence the way they talk about and present their gender identity. And as their thinking evolves and their understanding of what this means for them, both individually and socially, evolves, their goals evolve and their priorities evolve. And that's actually what this affirming care model is really uniquely positioned to do, is to really meet a person at every single point along their own pathway and say, how are you doing? What is this meaning for you right now? And how are you thinking about this moving forward? So the model is really designed to be adaptive and dynamic, and not to make assumptions or put people on a conveyor belt towards a predetermined path.
Thank you. And please understand, I think all of us are trying to understand this better. It's an emerging area for many of us. But I've read about other dysphoria related to a person's perception of their body. And I'm not aware of any other dysphoria other than gender dysphoria that's treated by affirming the individual's perception. I'm also not aware of any other dysphoria that could potentially be treated by surgery. As a psychiatrist, is that a correct understanding, or am I missing something in my own research?
So, well, I have a couple of things. So I think first of all, there actually are other mental health conditions that do involve physical changes. So for example, if you have severe depression, I can validate how depressed you feel as much as I want to, but it's unlikely that you'll feel less depressed unless I give you medication. Some people might need another kind of physical treatment, for example, transcranial magnetic stimulation, which uses magnets to stimulate specific parts of the brain to help treat their depression. So this kind of divide between the physical and the psychological, I think, is not as clean as we sometimes think it is. So I think that's kind of point number one. I think point number two is there are folks who have something called body dysmorphic disorder. And worse is a scenario in which someone is extremely distressed by a specific part of their body. Frankly, this is something that I wonder about every time I see a person who's presenting with gender dysphoria. I ask myself, is this possible? Is this something that could be going on for this person? What helps us feel confident that it's not body dysmorphic disorder is that body dysmorphic disorder is usually very specific to one part of the body. So it might be someone's nose, it might be their skin, it might be their calves, whatever the case may be. And socially affirming them otherwise does not take away that distress. For a young person with gender dysphoria, socially affirming their gender identity may not take away everything, but often really help reduce a lot of distress, especially for our younger patients. Also, similarly with body dysmorphic disorder, these folks as adults, they might go to a plastic surgeon and have treatment, and they still continue to experience distress either about the outcome of that particular surgery or something else. So the other difference is that, again, like people don't feel better when they've had that kind of treatment if they have body dysmorphic disorder, whereas folks with gender dysphoria do feel better, able to access that affirms their body goals.
Okay, last question, a lot simpler. Do you follow up with your patients especially after they are no longer pediatric patients, 5, 10, 20 years down the road, just to see how they're doing?
So we do stay in contact with patients, and patients are seen regularly by, especially by the medical team as they move through care. If someone's taking testosterone, they need to be seen, for example, every 3 to 6 months or once a year to get their prescriptions renewed and have laboratory monitoring. So yes, longitudinal follow-up is a routine part of care.
Okay. And I know we've gone a little bit over time because we have Dr. Daushin waiting in the wings. I think one or more members have some additional questions. Dr. Dalke, would you be willing to, if we submitted those in writing, to take a look at those? I think that Representative Daley and Representative Delisio, I think, had questions. Would that be acceptable to you if we just sent them via email?
Absolutely, I would be honored to do that. Thank you.
Okay, thank you. We're grateful for your time today. Thank you so much, Dr. Dalke.